Okay, so good evening from the Philippines. Can everyone hear me? Please give me a thumbs up. Send a quick message in the chat box so that we know that you can hear my audio. Okay, is everything okay? Can you guys hear me? Okay, so I think we have listeners from Luzon, Visayas, and Mindanao. So it's a time check. It's 8:38 Philippine Standard Time. We're about to begin a very life-changing live stream as our colleagues, our friends will be heading towards the upcoming exams. Okay. So great, loud and clear. Now this video will be made available for the entire public so that you can review this over and over again, most especially for those who would like to master everything before heading to the real exams. Okay. So since the audio is okay, let's begin. Let me share my slides. Okay, can everyone see the slides? Before we begin, can I see a message in the chat box so that we know everything is there? Can you guys see? Okay, great. So let's begin. Can I see you message in the chat box 100% so that I know everyone is on the same page with me? This is whether you're taking the boards or you have a friend or a colleague who is going to take the exam. So give me a shout out of 100%. So if you are taking the boards this coming week, you have a friend taking the boards, if you have a schoolmate, and of course, sooner or later, you will be taking the boards. Okay, great. Let me see that 100. Keep it coming. So we're going live, Philippines. And our friends from India, namaste. So good evening, everyone. I'm Dr. Toom, and this is CDB Reviews, way of sharing love with everyone, share the learning, and utilize the given opportunity of education. So for this evening, we're going to have a very interesting review. It's going to be a coaching format, given, of course, the master guru style. So welcome to my channel, MedGuru CDB. This is Dr. Toom, and let's start the ball. I will be giving a very high yield review, which is meant for PLE takers, board exam takers, medical students, interns, clerks. I will be utilizing 3 textbooks, particularly Robbins and Cotran, Pathologic Basis of Disease, BRS or Board Review Series Pathology, and of course, the Student Consult version of Robbins' Pathologic Basis of Disease. So let's begin. So these are the things which, according to the Master Guru's crystal ball, are the things that you have to remember not only for an exam, but also for your training, your clinical practice, the bedside pearls, and most especially everything you have to know as you handle future patients. So let's begin. Let's begin with the first condition, which is known as an omphalocele. This is also known as exomphalos and not exophthalmos. It sounds like exophthalmos, but it is not the bulging of the eyes. This is exomphalos, also known as omphalocele. Now, this is defined as the persistent herniation of a bowel into the umbilical cord. So your keyword here is omphalo and the umbilicus or the umbilical cord. Now, always remember, as you can see in the photo here, there's the presence of a sac. And this is what differentiates it from a gastroschisis. So this usually occurs in about 40% of patients. And 40% of these patients who have an omphalocele actually have an associated trisomy, particularly trisomy 13, 18, or 21. Now, can anyone tell me what is trisomy 13? What is the other name of trisomy 13? This is also known as Patau's syndrome. P for Patau is P for puberty, 13 years old. What is trisomy 18? Trisomy 18 is Edwards syndrome. This is a classic trisomy that usually presents with the rocker bottom feet as well as the clenched fists. So Edwards, letter E, stands for E, the election age, which is of course 18 years old. And of course, we have trisomy 21, which is the most common trisomy and the most common cause of congenital mental retardation, that is Down syndrome. Now, there are reports of omphalocele being associated with maternal smoking. So the keyword, if the exam is 5 minutes from now, is memorize the presence of a membranous sac. So if you write the letter O for omphalocele, just remember you have your viscus inside or your viscera. So the letter O is just like a membranous sac. Okay, now the other congenital malformation of the abdominal wall is a gastroschisis. Now, the other name of gastroschisis is laparoschisis. All of these things I am teaching you are lifted verbatim from the mother textbook. If you are cramming, if you are trying to repeat things to master things, then this would be a perfect review for you. So gastroschisis, also known as laparoschisis, is a congenital malformation of the ventral wall of the abdomen. Now, the defect is usually found on the right of the umbilical cord. And always remember that in a gastroschisis, it involves all of the layers of the abdominal wall. Now, question. Does a gastroschisis have a membranous sac? Is it a yes or is it a no? Does a gastroschisis have a membranous sac? So look at the letter G. Look at the letter O for omphalocele. Always remember the letter O looks like or symbolizes a membranous sac which surrounds the viscera. In gastroschisis, there is evisceration, or the viscera is literally popping out because there's no membranous sac. Okay, now Meckel's diverticulum, which is the most common congenital anomaly of the GI tract. Memorize that. Now, Meckel's diverticulum is actually a true diverticulum. This arises because of failure of involution of the vitelline duct or persistence of what we call the omphallomesenteric duct. Now, the usual location of a Meckel's diverticulum is usually on the antimesenteric side of the small intestines. Now, question, do we usually see a Meckel's diverticulum in the pediatric age group or the adult age group? Where do we usually encounter Meckel's diverticulum? Is it in the pediatric age group or is it in the adult population? So Meckel's diverticulum is classically seen in the pediatric age group. Okay, now I would like to remind everyone that Meckel's diverticulum arises because of persistence of the omphallomesenteric duct or failure of involution of the vitelline duct. Now, you cannot enter the testing site or the hospital corridors without knowing the famous rule of twos. Okay, the rule of twos of Meckel's diverticulum. So Meckel's diverticulum is found in 2% of the population. And it is usually located 2 feet or approximately 60 centimeters from the ileocecal valve. It is usually 2 inches long. It's 2 times more common in males, and it's usually symptomatic by the age of 2. And it has the presence of 2 ectopic tissue. So again, 2% of the population, 2 feet from the ileocecal valve, 2 inches long, 2 times more common in males, symptomatic by the age of 2, 2 ectopic tissues, and I would like to add 2 complications. And these 2 complications are usually bleeding, okay, and perforation. Obstruction would be third. Okay, so bleeding and perforation. So these are the 2 most common complications. Now, I would like to remind everyone that there are 2 ectopic tissues, which is gastric mucosa, as well as pancreatic tissue. Now, question, which of these heterotropic or ectopic tissue is the most common? Is it gastric or is it pancreatic? Which is the most common? Is it gastric or is it pancreatic? Which is the most common? Gastric tissue or pancreatic tissue? So it's usually gastric tissue. And of the complications, the most common complication is bleeding. In fact, I would like to remind everyone the most common cause of lower GI bleeding in children is a Meckel's diverticulum. The most common cause of lower GI bleeding in children is a Meckel's diverticulum. So please take note of that. Now, what do we call a hernia which contains a Meckel's diverticulum? This is what we call a Litter's hernia. This is a hernia that contains a Meckel's diverticulum. This is known as a Litter's hernia. Now, question, what do we call a hernia that contains an appendix? Okay, what do we call a hernia that contains the appendix? Okay, I'd like to hear, what do we call a hernia that contains an appendix? This is what we call an ambiens hernia. Okay, an ambiens hernia is a hernia that contains an appendix. Now next, pyloric stenosis. Now pyloric stenosis is the most common cause of bilious vomiting in a child. This is congenitally acquired, and the most common form of pyloric stenosis is the congenital hypertrophic pyloric stenosis. So there is hypertrophy of the pylorus muscle. Now, there is a report in our textbook that pyloric stenosis is associated with Turner syndrome. Now, what is the most common cardiac anomaly associated with Turner syndrome? The most common cardiac anomaly associated with Turner's syndrome. So Turner syndrome is usually associated with coarctation of the aorta, okay? Coarctation of the aorta. Now, I want everyone to remember, okay, that Down syndrome is usually associated with duodenal atresia or Hirschsprungs, okay? It's usually associated with duodenal atresia or Hirschsprung, and the most common cardiac anomaly associated with Down syndrome is endocardial cushion defect. While in Turner syndrome, the most common GI anomaly associated with Turner syndrome is pyloric stenosis, and the most common cardiac anomaly associated with pyloric stenosis is coarctation of the aorta. So please take note of this, okay? Coarctation of the aorta. So I hope everyone got this. Now, what are the key words we have to remember about congenital hypertrophic pyloric stenosis? So this is the pathogenesis. There is thickening of the sphincter wall. And this is because of smooth muscle hyperplasia. So this involves hyperplasia of the muscularis mucosae. Usual presentation is between the 3rd to the 6th week of life. So usually 1 month to a month and a half old. So it presents clinically with the symptoms of new onset regurgitation and projectile non-bilous vomiting. Now, I stand corrected. I think I mentioned most common cause of bilous vomiting. It's non-bilous vomiting. The most common cause of bilous vomiting, so take note of the correction. The most common cause of non-bilous vomiting in a child or a newborn is going to be congenital hypertrophic pyloric stenosis. Once it is bilous vomiting, then that is duodenal atresia because bile is found in the second portion of the duodenum. This is already at the level of the stomach, and there's no bile there yet. That is why it is non-bilous vomiting. Okay, now on physical exam, so anticipate that this is going to be presented as a case scenario. There's going to be a firm ovoid abdominal mass in 90% of cases. Now, would anyone happen to know what is the classic description of the mass? Okay, ano yung description ng mass? What is the shape of the mass? The mass is shaped like an olive. It's an olive-shaped mass, usually in the periumbilical or the epigastric area. It is an olive-shaped mass. Now, don't worry, all base members, all gold and platinum members, you will have access to the Google Drive, which has the study guide or the handouts of this presentation, okay? So please take note of this. We have an olive-shaped mass. Now, does anyone know who these two cartoon characters are? Who are these two cartoon characters? So on the left, we have olive oil. Okay. On the right, we have Popeye. Popeye the Sailor Man, and of course his infamous girlfriend, Olive Oil. Now, why am I showing you these two cartoon characters? because your symbolic mnemonics here is Popeye is associated with olive. Sino si Popeye? Popeye is Pyloric stenosis. Repeat, Popeye is Pyloric stenosis. Yung girlfriend niya is si Olive. Therefore, the Pyloric stenosis is associated with an olive-shaped mass. Okay, now, question. What antibiotics are associated with pyloric stenosis? And this is usually antibiotics which are either taken orally by the child or antibiotics whose metabolism is going to pass through the mother's milk. What antibiotic is associated with pyloric stenosis? Okay, very good. It's your macrolides, erythromycin or azithromycin. This is usually when the mother takes these antibiotics and the child is less than 2 weeks old, or this is during the first 2 weeks of life. So erythromycin or azithromycin, the macrolides. Now, next disease in the textbook is Hirschsprung's disease. This is also known as congenital aganglionic. Let me emphasize on the A, which is the absence of the ganglion. It's the aganglionic megacolon. So in pediatrics, when you hear megacolon, the first disease that should pop into your head is Hirschsprung's until proven otherwise. Now, what is the pathogenesis in Hirschsprung's disease? Now, tip, if you want to crack the pathology, the medicine, the pediatrics exam, always master the pathogenesis or the pathology, which is always found in the green and blue boxes in Robin's pathologic basis of disease. So Hirschsprung's disease results from the premature arrest of the neural crest. Okay, there is neural crest migration. And as a result of the premature arrest of the neural crest, what will happen? There's going to be absence of the myenteric and the Meissner's plexus. Now, just a simple reminder to everyone, okay? Meissner's has the double S. Therefore, Meissner's is associated with letter S, and that is secretions. Okay, so please take note of that. Now, don't forget, our box is also the myenteric plexus. The myenteric plexus or our box plexus is responsible for motility. Okay. So there's going to be the absence of both the Auerbach's or myenteric plexus and the Meissner's plexus in the distal segment. So as a result of the absence of these two very important parts of the enteric nervous system, there's going to be dilatation or the formation of the megacolon. Now, pathogenesis. I want everyone to remember that there's a mutation in the RET gene, okay, the RET gene, similar to thyroid cancer, particularly papillary thyroid carcinoma, also resulting from a mutation in the RET gene. Okay, so Hirschsprung's disease. Now, the clinical presentation of Hirschsprung's is going to be the failure to pass meconium in the immediate postnatal life. Now, let me just share this with you. In your pediatrics textbooks, it's failure to pass meconium within the first 24 to 48 hours of life. Okay, failure to pass meconium within the first 24 to 48 hours of life. So simply do a physical examination. Look for the presence of an anus. If the anus is present, then you automatically rule out and imperforate anus as a differential diagnosis. So don't forget, failure to pass meconium during the first 24 to 48 hours of immediate postnatal period. Now, only two things I want you to remember when you hear the word megacolon. Actually, three things. Number one, if this is a newborn, think of Hirschsprung's. Okay? Think of Hirschsprung's disease. If this is an adult, you think of two conditions. One is ulcerative colitis. Okay? Second is going to be Chagas disease. Now, what parasite causes Chagas disease? What parasite causes Chagas disease? This is caused by Trypanosoma cruzi. So it also presents with a megaesophagus as well. So please take note of these keywords. Now here are some very important figures which are found in your mother textbook. So here, this is the megacolon. You have the dilated colon here, particularly the dilated sigmoid. So once you hear the word megacolon, okay? Now, this is your CDB Guru Guide. As I mentioned earlier, these are the keywords when you hear the word megacolon: Chagas disease, megacolon, and ulcerative colitis. Now, I just want to add that ulcerative colitis, okay, is going to have the famous collar button lesions. Okay, this is the inflammatory bowel disease that presents with the collar button lesions. Now, do not mix this up with Crohn's disease. Okay, Crohn's disease, which has the skip lesions. It has the cobblestone appearance. Okay, so do not mix them up. So Crohn's disease has the skip lesions, and we have the cobblestone appearance. Okay. Now next is diffuse esophageal spasm. This is also known as the corkscrew esophagus. So as you can see here, look at this beautiful barium studies showing you the famous corkscrew appearance. Now, what if I tell you it's a bird's beak appearance? What is your diagnosis? If there is a bird's beak, this is now achalasia until proven otherwise. Okay, so please take note of this, achalasia. So this is the features of diffuse esophageal spasm. There's repetitive, simultaneous contractions of the distal esophageal smooth muscle. So again, repetitive, simultaneous contractions of the distal esophageal smooth muscle. And that is the diffuse esophageal spasm. Okay, now here, beautiful pictures from Harrison's Internal Medicine. Tingnan mo yan. Look at that. Okay, corkscrew appearance. Okay, I hope that helps you associate better. Now, the triad of achalasia. So first, it's the LES relaxation. Again, it is relaxation, not contraction. There's an incomplete lower esophageal sphincter relaxation. There's going to be increased tone, so decreased LES relaxation. There's going to be increased LES or lower esophageal tone. And there's going to be the characteristic absence of peristalsis of the esophagus. Okay. So this is the classic triad of achalasia. Now here, this is the bird's beak appearance. Okay, that is the bird's beak appearance. And this is how it looks in Harrison's. Okay, we have the tapering of the esophagus distally. So that's very classic. Then we have the Mallory-Weiss tear, which is usually associated with alcoholism as well as bulimia. So there's usually severe retching or severe vomiting. There's going to be linear lacerations along the gastroesophageal junction, and this is usually going to present with hematemesis. So there's going to be upper GI bleeding. So linear lacerations, which are oriented longitudinally along the long axis of the esophagus. So most common site is at the gastroesophageal junction. So the keywords here is severe retching. Now, what if I tell you there is history of GERD and there's symptoms of dyspepsia or acid rash? What is the first thing you should think of aside from peptic ulcer disease? Okay, what is the other thing you should think of? Okay, very good. You should think of Barrett's esophagus. Okay. Also think of Barrett's esophagus because of the association of. And don't forget, Barrett's esophagus is a precursor for cancer, okay, particularly adenocarcinoma of the esophagus. Now, what about Voorhees syndrome? This is known as pressure rupture of the distal esophagus. You're going to present with pneumomediastinum, and you're going to have this physical exam finding known as Hammond sign, which is described as a crunching sound on auscultation. Now, do not mix this up with Hohmann sign, which is pain on dorsiflexion of the foot, and this is seen in deep venous thrombosis. Do not mix up Hammond with Hohmann sign. So you have the Voorhees syndrome. Okay, this is pressure rupture of the esophagus. This is a medical and surgical emergency. So there's the presence of pneumomediastinum. I'd like to share with everyone here that we have the famous triad, okay, in Voorhees syndrome. This is known as Meckel's triad. It presents with subcutaneous emphysema, vomiting, and abdominal pain. Again, Meckel's triad is seen in Voorhees syndrome. There's vomiting, there's pain, and there is subcutaneous emphysema. Okay, vomiting, abdominal pain, and subcutaneous emphysema. This is Meckel's triad. Now, do not mix this up with Anderson's triad. So here's another guru guide. Anderson's triad is seen in esophageal rupture. There is now an associated rapid respirations. The patient is tachypnic, okay, increase in RR. There's abdominal rigidity, which indicates this is an acute surgical abdomen. And there's the presence of subcutaneous emphysema. So this is Anderson's triad. Again, you can review this video anytime. This is going to be available in the site forever. Okay, so next is gastric adenocarcinoma. Okay, now always remember gastric adenocarcinoma is the most common malignancy of the stomach. It comprises about 90%. It comprises about 90% of all gastric cancers. Okay, So it is gastric adenocarcinoma. Now, these are the risk factors which are mentioned in Robbins. Number one is H. pylori infection. And number two is the ingestion and exposure, chronic exposure to dietary carcinogens, particularly nitrosamines or N-nitroso compounds, as well as benzopyrenes. Now, can you tell me what type of food or what type of food products are associated with high levels of N-nitroso compounds and benzopyrenes? So the foods you see here, we have preserved foods, smoked foods, barbecues, grilled foods. So those with preservative. So very classic nitrosamines, very common in the Asian diet. Now, I want everyone to master the role of the E-cadherin. Okay, the E-cadherin plays a role in cell adhesion. In the pathogenesis of gastric carcinoma, there is loss of E-cadherin. Therefore, there is loss of cell adhesion. So E-cadherin loss is a key step in the development of diffuse gastric cancer. Now, let's dissect the textbook. In the diffuse infiltrative growth pattern of gastric adenocarcinoma, everyone has to memorize the famous signet ring cell. So this is the signet ring cells that you see there. If you notice, you have a crescent-shaped nucleus, and you have, it is peripherally displaced, okay, just like a signet ring. So this is diffuse infiltrative growth pattern. Now, this is the classic description of gastric adenocarcinoma when you have a lesion. So look at this one on top, okay? So we have here the elevated lesions. We have elevated lesions. We have here an elevated mass with heaped up borders with central ulceration. So here are the heaped up borders. And here's the central ulceration. Now, the photo below, which is discussed in your mother textbook, this is the classic infiltrative type, which is known as Linitis plastica, also known as the leather bottle appearance. Okay, Linitis plastica. So as you can see, especially here in this area, you have here the thickened gastric walls, okay, and the loss of the rugal folds. This area here, this is classic of diffuse infiltrative gastric carcinoma, which carries a very poor prognosis. Now, as for the manifestations, although it is discussed that gastric adenocarcinoma usually has vague symptoms, and by the time there are symptoms, it's usually advanced. The common symptoms would include weight loss, anorexia, early satiety, anemia, and hemorrhage. So weight loss, anorexia, early satiety, anemia, and hemorrhage. Pay attention to the first two, okay? Now, as mentioned, usually gastric carcinoma is diagnosed in its advanced stage. So we have some signs on physical exam, which is indicative of advanced stages of gastric carcinoma. So number one, we have the Virchow's nodes, We have the sister Mary Joseph's nodes. We have the Bloomer's shelf, and we have the Krukenberg tumor. Virchow's nodes. We have the sister Mary Joseph's nodes, the Bloomer's shelf, and the Krukenberg tumor. Now, Virchow's, this is the supraclavicular lymph nodes. So I usually remind students of the letter V, like a V neck shirt. When you wear a V neck shirt, you are exposing your clavicles. So supraclavicular lymph node, also known as the sentinel node. In Harrison's, we call this the seat of the devil. Okay, so Virchow's nodes. Do a biopsy of that lymph node, and it's going to reveal advanced gastric carcinoma. Then, of course, we have Sister Mary Joseph's nodes, which is the periumbilical lymph nodes, named, of course, after Sister Mary Joseph, who you see here on the left. So, nag-metastasize na yung gastric carcinoma. Then we have Bloomer's shelf, which is metastasis to the pouch of Douglas, or the rectouterine pouch of Douglas. So don't forget, the rectouterine pouch of Douglas can be accessed through the posterior fornix of the vagina. The rectouterine pouch of Douglas, also known as the cul-de-sac of Douglas, is the most dependent portion of the peritoneal cavity when the patient is in standing position. So metastasis to the pouch of Douglas, or the cul-de-sac, this is known as Bloomer's shelf. Then metastasis of a gastric carcinoma to the ovaries, this drop metastasis is known as a Krukenberg tumor. Okay, it is known as a Krukenberg tumor. Now, next is gastric lymphoma. Now, I want you to remember gastric lymphomas are usually found in the stomach. Now, the reason why the bowels, okay, are associated with gastric lymphomas is because of the presence of the lymphoid tissue, okay? The gastric mucosa associated lymphoid tissue, or the MALT. That's why we have tumors, which we call maltomas, or the gastric mucosa associated lymphoid tissue lymphomas, the maltomas. Now, there is a virus that is associated with B-cell lymphoproliferation, and that is Epstein-Barr virus. If you recall, Epstein-Barr virus is associated with nasopharyngeal carcinoma, it's associated with Burkitt's lymphoma, and it's associated with Hodgkin's lymphoma. Now, according to Robbins, the most common type of gastric lymphoma is the marginal zone B cell lymphoma. Okay, the marginal zone B cell lymphoma. And there is a quick discussion in your textbook mentioning the role of the chemo drug cyclosporine, okay, being used, and there's an increased rate of gastric lymphomas, okay? Then we mentioned the neuroendocrine neoplasms, which more than 40% of them are found in the small intestines. The other are found in the pancreas. Now, of the neuroendocrine tumors, these are the things you have to remember. Number one, the association with autoimmune chronic atrophic gastritis. Number two, multiple endocrine neoplasia type 1. Number three, Zollinger-Ellison syndrome. And number four, carcinoid tumor. Now, do not forget Zollinger-Ellison syndrome. This is associated, this is an islet cell tumor, which is associated with gastrinoma. And men type 1, this is also associated with other tumors like pheochromocytoma, as well as medullary thyroid cancer. Now, chronic atrophic gastritis, this is type A, which is autoimmune. Type A is A, autoimmune. Type B is letter B, It's associated with bacteria, and that bacteria is H. pylori. Type C, chronic atrophic gastritis, is C. It's chemical induced. This is the one associated with the NSAIDs. Okay, so please take note of this. Now, what about the carcinoid tumor? Now, please do not forget this produces 5-HT, which is also known as 5-hydroxytryptamine. This produces serotonin. Can anyone tell me what amino acid gives rise to serotonin? What amino acid gives rise to serotonin? Okay, what amino acid gives rise to serotonin? It is tryptophan. And don't forget, tryptophan comes from niacin or vitamin B3. So this is carcinoid tumor, which is usually found in the small intestines. It's also found in the appendix. It's also found in the stomach. Now here, encircled, this is your carcinoid tumor, or boxed out rather. Then we have the famous tumors, which arise from the interstitial cells of Cajal. Can anyone tell me what tumor arises from the interstitial cells of Cajal? The interstitial cells of Cajal is what we call the pacemaker cells of the gastric mucosa. So this gives rise to the gastrointestinal stromal tumors, or the GIST. A gastrointestinal stromal tumor, or the GIST. Now, 75%, memorize this for pathogenesis if you want to crack the boards wide open. 75% of GIST is associated with a mutation of c-KIT. About 8 to 10% is associated with a mutation of PDGFRA, or platelet-derived growth factor receptor alpha. Memorize the c-KIT. Now, the GIST is considered to be the most common mesenchymal tumor of the abdomen. The most common mesenchymal tumor of the abdomen. Okay, now, can anyone tell me what is the triad of non-hereditary syndrome of GIST? So GIST, paraganglioma, and a pulmonary chondroma. What do we call the triad of GIST, paraganglioma, and pulmonary chondroma? So please take note, GIST, paraganglioma, and chondroma. So this is, of course, known as Carney's triad. Now, there is a syndrome mentioned in Robbins, which is associated with an increased risk of GIST, an increased risk of developing a paraganglioma. Okay. And what is this syndrome? The pathogenesis here is the loss of succinate dehydrogenase function. This is known as Carney-Stratakis syndrome. So just remember, S for Stratakis is S, loss of succinate dehydrogenase function. So Carney-Stratakis syndrome. So please take note of this, okay? Carney-Stratakis. Now, do not confuse Carney's triad with Carney's complex. Carney's complex presents with the freckles, okay, which is lentiginous spots. It presents with a cardiac tumor, particularly a cardiac myxoma. It also presents with an adrenal tumor, and it presents with a peripheral nerve sheath tumor, particularly a schwannoma. Carney's triad is different from Carney's complex. So please take note of this, okay? So here's Carney's complex, lentiginosis, which is the freckles. It has myxoma. Cardiac, it can also present with a skin myxoma. Here's a nodular tumor of the adrenals. So this is Carney's complex, okay? Now, the discussion of intestinal obstruction in the textbook. 4 major causes of intestinal obstruction. Number 1, herniation. Number 2, adhesions. Number 3, volvulus. Next is intussusception. Herniation, adhesions, volvulus, and intussusception. So don't forget herniation, okay, pathogenesis. This is how we crack your exams. So stasis and edema occurs as a result of the herniation. This leads to a permanent entrapment, which of course leads to incarceration. There's now compromise of the arterial and venous flow, which leads to strangulation and eventually infarction. So that is now your emergency once there's strangulation. Now here, for the Philippine boards, the examiners love to lift verbatim from the green and the blue boxes and the descriptions of the figures. So we have here the dusky areas of the serosa with associated hemorrhage. Okay, the dusky areas of serosa with associated hemorrhage. This is indicative of ischemic damage. Again, this is indicative of ischemic damage. Then we have volvulus, which is defined as a loop of bowel that twists about its mesenteric point of attachment. Now, where is the most common site of volvulus? Where? Most common site of volvulus. Nasaan? Asaman. Where is it? It is found in the sigmoid. Okay? Sigmoid is the most common site of volvulus. Pathogenesis. Why is it found in the sigmoid? This is because of the redundant sigmoid. Okay, this is because of the redundancy of the sigmoid. It's the redundant loops. So what happens in volvulus is compromise of both luminal, so there's obstruction, as well as the vascular compromise. So this is you're dealing with number 1, obstruction, number 2, infarction. So because of the redundancy, okay, of the sigmoid loops, this will explain why it's the most common site of volvulus. Now, according to the textbook, after the volvulus follows the cecum, then the small intestines, then the stomach. Okay, now, ischemic bowel disease. It is highlighted in the book that the most important risk factor for thrombosis is severe atherosclerosis. Okay, and the most common site of ischemic bowel disease is found in the watershed areas, particularly the splenic flexure and the rectosigmoid area. So this is where you have the connection or communication or junction of 2 different blood supplies. So what is the blood supply up to this area? This area here, this area of the transverse colon. What is the blood supply here? This is the SMA. or the superior mesenteric artery. Beyond this point, which I highlighted, this now becomes the inferior mesenteric artery. Now, what do we call this specific area? This is what we call Griffith's point at the splenic flexure. That's the most common site of ischemic bowel disease. The second is Sudek's point, which is found more distal at the rectosigmoid area. So please take note of that. Okay. Now, what about the pseudomembrane formation? This is associated with the bacteria Clostridium difficile. Okay, this is the Clostridium difficile associated colitis. The usual case here is someone on prolonged intravenous antibiotics. Okay, and they present with diarrhea. That is the most common manifestation of pseudomembranous colitis. Most common culprit, okay, is going to be the antibiotic clindamycin. Okay, clindamycin. If you follow Harrison's, it's clindamycin, cephalosporins, quinolones. Treatment. What is the treatment? Okay, the treatment is going to be metronidazole. If there is going to be severe, moderate to severe, then you treat with vancomycin. Okay. Please take note of these pearls that I'm trying to teach you. Classic case, antibiotic use, presenting with diarrhea, especially if they're hospitalized. Most common cause is usually clindamycin, followed by cephalosporins. Then we have quinolones. Treatment is metronidazole. Moderate to severe is going to be vancomycin. So please take note of this. Now, I'm going to give you this case of a preterm neonate who presents with abdominal distension, poor feeding, and abdominal discoloration. What is your primary consideration? A preterm neonate with abdominal distension, poor feeding, and abdominal discoloration. This is the finding. This is the X-ray on the left. You did an exploratory laparotomy, and you noted necrosis of the bowels. This is necrotizing enterocolitis. Okay, necrotizing enterocolitis, which is the most common abdominal emergency in the neonate. Now, these are your keywords. These are your keywords or your buzzwords for necrotizing enterocolitis. Number one, the preterm neonate. Okay, so the risk increases the more preterm the baby is. Next is the abdominal distension and the X-ray finding, which we call the intestinal pneumatosis. Memorize that. So please take note of this, the intestinal pneumatosis. Okay. So this is going to end our quick session. And we basically dissected the mother textbook. So this is the master guru, Doc Toom, saying thank you for joining. Thank you for listening. You can view again the video. It's going to be available for a lifetime. And for those who are taking the March PLE a few days from now, please join us. Make the wise last move. Join our last ditch coaching. This will be purely online. This will be March 1, 2, and 3, March 7, March 8, and March 9. For details, just message Doc Toom at 0917-720048. So thank you very much for listening. God bless. Study hard, study wise. CDB loves you. Thank you.